Dear colleagues, welcome to this OncoAlert Session Round Up during ASH 24. Today's roundup is on multiple myeloma, focusing on pharmacologic therapies, refining the evidence. We start off with a concomitant publication out on JCO for the Phase 3 GMMGHD7 trial, isatuximab, lenalidomide, bortezomib, and dexamethasone induction therapy for transplant-eligible patients with newly diagnosed multiple myeloma. Final progression-free survival analysis. The GMMGHD7 trial evaluated the addition of isatuximab, or Isa, to the standard lenalidomide bortezomib dexamethasone, or RVd, regimen in transplant-eligible patients with newly diagnosed multiple myeloma. In Part 1 of the study, 662 patients were randomly assigned to receive either Isa-RVd or RVd, followed by autologous stem cell transplantation, and a second randomization to maintenance therapy with lenalidomide alone, or Isa-lenalidomide. As of January 2024, patients treated with Isa-RVd demonstrated significantly higher MRD, or minimal residual disease negativity rates after transplant, 66% versus 48% in the RVd group. Isa-RVd also significantly improved progression-free survival compared to RVd, regardless of the maintenance therapy used, with a hazard ratio of 0.70. An additional analysis confirmed statistically significant PFS benefit when Isa-RVd induction therapy was followed by lenalidomide maintenance. These results highlight the efficacy of adding Isa to RVd, showing sustained MRD negativity and prolonged PFS after transplant, even without consolidation therapy. The second trial is a Phase 3 IMROZ trial, analysis of minimal residual disease negativity dynamics. This is on isatuximab, bortezomib, lenalidomide, and dexamethasone, or Isa-RVd, in patients with newly diagnosed multiple myeloma. The Phase 3 IMROZ study evaluated the addition of isatuximab, or Isa, to VRd regimen in transplant-ineligible patients with newly diagnosed multiple myeloma. The combination of Isa-RVd followed by Isa-RD demonstrated significantly improved progression-free survival and deeper, more sustained minimal residual disease negativity compared to VRd alone. By month 36, 68.6% of patients with Isa-RVd achieved MRD negativity versus 50.8% in the VRd group. Additionally, sustained MRD negativity at 12, 24, and 36 months was significantly higher with Isa-RVd, showing a consistent benefit over time, including improved conversion rates from MRD positivity to negativity during the maintenance phase. These findings highlight the enhanced efficacy of Isa-RVd, with patients showing faster and more durable responses than those receiving VRd alone. The Isa-RVd regimen also led to lower rates of MRD loss during maintenance and a higher rate of sustained MRD negativity, which correlates with longer PFS. The result emphasizes the role of Isa as a valuable addition to both induction and maintenance therapy in transplant-ineligible new diagnosed multiple myeloma patients, providing a compelling rationale for its use and improved long-term outcomes. The third trial is a final analysis of the randomized UK MRA Myeloma XI Plus trial examining KRDC, carfilzomib, lenalidomide, dexamethasone, and cyclophosphamide as induction therapy for newly diagnosed multiple myeloma patients. The UK MRA NCRI Myeloma XI Plus Phase 3 trial compared intensified induction with carfilzomib containing quadruplet regimen KRDC to a response-adapted approach using sequential triplet therapies, CRD and CTD, in newly diagnosed multiple myeloma patients. Updated analysis after a median of 102 months of follow-up confirmed that KRDC significantly improved progression-free survival with a median of 56 months versus 37 months for CTD-CRD. This benefit was seen across various cytogenic risk groups, including high-risk and ultra-high-risk patients. MRD negativity was achieved more frequently in KRDC groups, and early MRD negativity correlates with improved PFS. Despite no significant difference in overall survival in contemporaneously randomized patients, the inclusion of non-contemporaneous controls showed a significant OS benefit for KRDC. These results suggest that a combination of carfilzomib with an immunomodulatory agent, dexamethasone and cyclophosphamide, leads to deeper responses and significantly longer PFS compared to the triplet regimens. The significant OS improvement seen in patients with high-risk disease underscores the potential clinical benefit of early aggressive treatment with KRDC. The study also highlights the importance of achieving MRD negativity early, which was more frequently observed with KRDC. This approach has contributed to ongoing improvements in treatment outcomes for newly diagnosed multiple myeloma patients, supporting its continued use in clinical practice and further studies across the UK clinical trials. The next trial is the DREAMM-7 trial with overall survival analysis and updated efficacy. This is on belantamab, mafodotin, bortezomib, and dexamethasone versus daratumumab, bortezomib, and dexamethasone in relapsed refractory multiple myeloma. The DREAMM-7 phase 3 trial compared the efficacy and safety of two triplet regimens, belantamab, mafodotin, bortezomib, and dexamethasone, or VVD, versus daratumumab, bortezomib, and dexamethasone, or DVD, in patients with relapsed or refractory multiple myeloma who had received at least one prior line of therapy. The trial made its primary endpoint with VVD showing a significant progression-free survival benefit, achieving a median PFS of 36.6 months compared to 13.4 months with DVD. Additionally, VVD resulted in higher rates of complete response and minimal residual disease negativity and a longer duration of responses. Treatment benefits with VVD were sustained even after subsequent therapies, with improved PFS2 and early overall survival trends favoring VVD, with 18 months OS rates of 84% versus 73% for DVD. These findings suggest that VVD may become a new standard of care for patients with relapse or refractory multiple myeloma at their first relapse or later, offering superior PFS, OS, DOR, and MRD negativity rates compared to DVD. Although median OS was not reached in either arm at first interim analysis, the predicted median OS for VVD was 84 months compared to 51 months of DVD. VVD also maintained durable and deep responses with sustained benefits after subsequent therapies. The safety profile was consistent with previous studies with manageable ocular events and low discontinuation rates. These results highlight VVD as a promising new treatment option with the potential to change clinical practice for relapsed refractory multiple myeloma. And we finish off with another concomitant publication, and this time out in the New England, daratumumab monotherapy versus active monitoring in patients with high-risk smoldering multiple myeloma, primary results of the AQUILA study. This phase 3 trial investigated the efficacy of subcutaneous daratumumab, an anti-CD38 monoclonal antibody, as a treatment for high-risk smoldering multiple myeloma, a precursor to active multiple myeloma to which no approved treatment currently exists. A total of 390 patients were randomly assigned to receive either daratumumab monotherapy or active monitoring. With a median follow-up of 65.2 months, daratumumab significantly reduced the risk of disease progression or death by 51% compared to active monitoring. At 5 years, progression-free survival was higher in the daratumumab group compared to the active monitoring group. The study also found that overall survival at 5 years was 93% with daratumumab versus 86.9% with active monitoring. Daratumumab was well tolerated, with hypertension being the most common grade 3 to 4 adverse event, occurring in 5.7% of patients. Adverse events led to treatment discontinuation in 5.7% of daratumumab group, but no new safety concerns were reported. Overall, daratumumab monotherapy was shown to significantly lower the risk of progression to active multiple myeloma and improve survival outcomes in high-risk smoldering multiple myeloma patients. And that about wraps it up for this session, and we thank you for your support and hope you're enjoying ASH 24.